Welcome to the Journal Club, an online resource developed by CLD, the multimedia journal for the American Association for the Study of Liver Diseases. The Journal Club is designed to highlight recently published impactful research reviewed and discussed by leading experts in the field and presented in a video platform easily accessible by all providers caring for the patient with liver disease. There is no better time than now, especially in light of the global pandemic of COVID-19, to present the community of liver providers a resource to stay up to date on clinical research that can impact their practice. Co-moderating this inaugural session with me is Dr. Julius Wilder of Duke University. Julius?
Thank you. Happy to be here. Excited.
My name is Steve Scaglione of Loyola University Chicago. Today's expert panel consists of Dr. Reddy, Professor of Medicine at the University of Pennsylvania, and Dr. Bajaj, Professor of Medicine at Virginia Commonwealth University, who will also be presenting our first article on mortality risk among patients with cirrhosis and COVID-19. Without further ado, Dr. Bajaj.
Thank you. Thank you, Dr. Scaglione. Thank you, Dr. Wilder, and thank you, Dr. Rowe. And thank you for CLD for this innovative multimedia approach to actually keeping us engaged during this pandemic. This was a multi-center study, and one of my co-authors, Dr. Reddy, will also be at our hand to ask questions and give deeper insights a little bit later. This study was done across 7 centers across North America, and it compares the mortality risk in patients with cirrhosis with COVID-19 compared to those with cirrhosis alone and those with COVID-19 alone. And we matched them. This was done across, we ended up having 37 patients with cirrhosis plus COVID-19 who were hospitalized. So these were hospitalized patients matched between May and March 2020. And we followed them while they were in the hospital for their outcomes, both related and unrelated to COVID. We matched them through 108 patients who were admitted with COVID-19 alone and 127 patients who were admitted with cirrhosis alone, basically to get both a positive and a negative control. Race and ethnicity across the groups are very similar. And what we found is that patients who had cirrhosis plus COVID-19 had a very high mortality compared to those who were admitted with COVID-19 alone. This is 30 versus 13%, and this was statistically significant. However, when we compared patients with cirrhosis and COVID-19 to those who were hospitalized with cirrhosis alone, this, even though it was numerically higher, 30% versus 20%, it did not reach statistical significance. What we ended up finding was that patients with cirrhosis plus COVID-19 versus those with COVID-19 alone had equivalent respiratory symptoms, chest findings, and rate of ICU transfer and ventilation. However, those with cirrhosis COVID-19, of course, had a higher comorbid conditions, and ultimately, the comorbid conditions are what predicted who unfortunately lived or died in this situation. We also found that people who had cirrhosis plus COVID had lower presenting GI symptoms. So as you've realized, a lot has been made in the literature about diarrhea, etc., as a presenting symptom for COVID. What we found is the patients who had cirrhosis plus COVID were less likely to present with predominant GI symptoms than those who had COVID-19 alone, making this kind of an unreliable way to diagnose COVID or at least suspect COVID in our patients with cirrhosis. And they not only did worse, they had worse lactate, worse MELD score than the other group. What we also found that patients who had cirrhosis plus COVID behaved like bad COVID patients, whereas patients who had cirrhosis got all the complications that you would normally expect for someone who's hospitalized with cirrhosis, like hepatic encephalopathy, GI bleeding, infections, etc. What's worse, at this point, because we only ended up admitting patients who were much sicker than what we would have in a prior study, in a prior realm, patients with cirrhosis, regardless of COVID, had a higher ACLF rate, which means acute and chronic liver failure rate was almost 30% in the patients with cirrhosis who were admitted, regardless of COVID. And when you look at historical data, even though this was contemporaneously corrected, historical data, typically the NACSELD ACLF rate is around 10%, which is a testament to the fact that how sick these patients were to require admission, even when the fear was the greatest of COVID in the early March, April, and May kind of situation. So what we ended up finding is the Charlson Comorbidity Index, which is a validated way of knowing who has worse comorbidities, was the only variable that ended up predicting mortality. So what we found is in this multi-center North American experience, inpatients with cirrhosis and COVID-19 had higher mortality risks than inpatient with COVID-19 infection alone. In the risk of mortality in hospitalized patients with cirrhosis and COVID-19, however, was not significantly higher, even though it was numerically higher in those with cirrhosis without COVID-19. And patients with cirrhosis hospitalized for COVID-19 are more likely to develop complications related to the viral infections. And their ACLF was predominantly driven by the intubation and all the respiratory failures, whereas in patients who had cirrhosis alone, the ACLF was driven by renal failure and neurological impact. Patients with cirrhosis and COVID-19 are less likely to present with GI symptoms compared with those with COVID-19 alone. And I think we are thankful to GUT for publishing this paper, for a rapid review. And we are also thankful to everyone across the 7 sites, the coordinators, and of course the patients who helped us make this into this report.
Thank you so much for that wonderful sort of overview, and congratulations on this extremely important and impactful study. Your guys' ability to get this together in a timely fashion to provide such helpful information is really, really amazing. A couple questions as we kind of think about this and what it means and the scope of it moving forward. The study sheds light on the mortality risk of COVID-19 infection in patients with cirrhosis. What is unique about COVID-19 in patients with cirrhosis, though?
So obviously, some other studies and our studies have shown that cirrhosis does increase the risk of dying with COVID. What we found in our study was our key strength was the contemporaneous age and gender matching. So some studies have compared the risk of death in patients enrolled today to patients who were enrolled like last year. And as we know, the ACLF rate has gone up because our threshold for admission is much, much higher currently than it probably was a year ago. Therefore, comparing apples to apples at this stage, we find that cirrhosis plus COVID may be diagnosed a little bit later, at least in this initial 2 or 3 months where the fear of not being exposed to COVID was the greatest. It may have reduced the patients with cirrhosis ability to come forward with issues until it was too late. And because they were also compromised as far as the Charlson comorbidity index, ultimately that's what determined whether they were alive or not. And again, as you know, this is a very selected population who was considered sick enough to be hospitalized across several centers. So this is obviously a microcosm of the big universe of cirrhosis and COVID that is out there.
In regards to the Charlson comorbidity index that you identified in your regression analysis as a major predictor of mortality, in your clinical experience with COVID, are there any complications of cirrhosis, maybe other than HBS and portal pulmonary hypertension, that would particularly worry you in the management of a decompensated cirrhotic with COVID-19? And then are there any etiologies of cirrhosis you find that have a particularly higher mortality rate? And how about concurrent alcohol use, malnutrition, uncontrolled diabetes? It's a big question, so just trying to get your clinical experience in the landscape of these very complex patients.
So these are very important questions. Some of them may be very difficult / impossible to answer because the N was only 37. And if you look at studies around the world, it seems like the N is relatively low for patients who have cirrhosis plus COVID if they were actually, if you systematically study it out of registries. What we did find, the comorbidity index, as you know, has multiple areas of the body in there and not specifically one. And the index doesn't really, you can't have a sub-index in there because we didn't have the N. Studies, though, have shown, regardless of COVID, which really you can think of as a severe infection, severe viral infection, in patients who have infections other than COVID, all the same issues, the worse your liver diseases, the more alcohol comes into play, the more sarcopenic you are, more likely it is that those patients are not only go to the ICU quicker, they're much more likely to not survive intubation because of all these pre-existing conditions. However, we need to do much larger studies in not just the hospitalized patients, but patients who are, as an outpatient who are suffering from COVID.
Thank you for that. So Dr. Bajaj, given that in the management of your hospitalized patients with cirrhosis, how's your practice changed during the time of COVID-19?
In patients who have been, our practice has changed. And remember, this was April, May, and March, where we were really grappling for any straws to come from.
Yeah.
Right now, I mean, I wouldn't say we are more confident, but we are less unconfident, whatever you want to call it. We are much less confused in the way in which we manage patients. And what we are, every institution has their own protocol of how to do it. We thankfully have enough PPEs to actually go around. But we do realize that, and the public has also kind of realized that, if you fear of COVID so much, and if you have decompensated cirrhosis and you neglect taking care of your decompensated cirrhosis, it can actually, that mortality rate from that can be much higher, especially when we talk about people who have relapsed into alcohol. We talk about people who may have a missed HCC, people who have not controlled their, electrolytes. Those are all the things that we have to actually do a better job educating our patients. And I think we are finally getting through to them, because it's kind of settled into something that we now have to deal with day in and day out, rather than this acute hysteria that we had before about, not knowing anything. Now we know that we have to manage chronic diseases also with respect, and not just shunt everything back because of COVID's issue.
Excellent answer. Dr. Reddy, in this study, I found interesting that 3 uninfected patients with cirrhosis received a liver transplant, which is somewhat encouraging given the fact that liver transplants had decreased during this time. So if a patient with cirrhosis were to contract COVID-19 and decompensate, how do you feel that an institution should approach them regarding transplant, and what criteria would you feel needed to be fulfilled prior to transplant?
First of all, thanks to Julius and Steve for this opportunity to talk about cirrhosis transplant in the context of COVID-19. So it's an important question that you addressed. The 3 patients who were transplanted were not with COVID-19. So during the pandemic, transplants went down primarily because there was concern about organ procurement, and there was a decrease in organ donation, and live donor liver transplants went down. Yet Medicare had designated this as a situation that should go on regardless of the pandemic, and so transplants went on. But now you was asking a loaded question. What if the patient contracted infection? What do you do? Right now, speaking to transplant programs around the country, even when there's an acute liver failure, they are concerned about transplanting someone with COVID-19. So we have not done any transplants in someone who's been infected. There's a requirement for at least a 2-week window after diagnosis, and they want at least 2, maybe 3 tests to be negative before we would take them in. Fortunately, we have not been faced with that situation, I must say. But if that were to be the case, that's what our requirement would be.
Thank you for that, Dr. Reddy. And so it sounds like, you and like many institutions have made some adjustments to your approach around transplantation at the facility and in the way you approach it. Maybe could you talk a bit more about some of the things you guys did specifically around approaching transplantation, but also speaking to how you think institutions should consider adjusting post-transplant immunosuppressive regimens or protocols?
Right. It's a great question, Julius, because automatically you would think, well, viral infection, immunosuppression, that's bad. But that's not necessarily the case. You also have to look at the risk benefit of adjusting immunosuppression. During the initial period when the cases were being seen in the epicenter like New York, they adjusted immunosuppression primarily with by reducing or holding the anti-metabolite, CellCept, or azacitidine, without reason. But subsequently, we learned that immunosuppression does not really, that adjusting that would not in any way prevent it, and that these patients are not at any greater risk of mortality. There's a very nice paper that came out from your backyard, among other centers, the COVID HEP and Secure Cirrhosis website, they, with the multiple other sites, have just published a paper in Lancet Gastroenterology Hepatology that liver transplant recipients are no greater risk of death than others with comorbidities. So we do not want to have a knee-jerk response and start tinkering with immunosuppression because the downside could be greater. So bottom line is treat them like any other time.
Great, thank you. So that leads into the next question. So you identified studies that show that the immunosuppression wasn't a real risk factor for COVID-19 mortality. When you see a patient who had post-transplant, has a liver transplant and maybe far out from liver transplant, how, in your experience, have you seen them faring? Do you think they have done pretty well? And do you change your management at all with the patient who's stable and pretty far out from liver transplant?
Right. So this is, again, an important question. So when we look at our experience, considering the number of patients we have who have been transplanted, it's a huge cohort. We've had less than 10 cases of COVID-19. And if you look at those cases, you know, there's only maybe 1 or 2 severe COVID-19 cases. Most of them were mild or moderate. So that's very reassuring. We have not changed immunosuppression at all in these patients. We've managed them the way we normally would. And in fact, I don't recall proactively changing any of their regimen in our cases. So I think it's very reassuring, particularly the recent paper that showed that it's liver transplant is not the variable, but the comorbid conditions that are the variable in outcomes. And we should not really be doing anything different than what we normally would do.
Thank you very much for that answer.
Yeah, so Dr. Reddy, I think I can predict your answer to our next question then, because we've been talking about transplantation. But you know, there are other scenarios where we're dealing with medications in our patients, particularly immunosuppressive medications, including, you know, high dose prednisone and azathioprine, for instance, in our autoimmune, you know, hepatitis patients. So, you know, if they are cirrhotic and on immunosuppression, as opposed to the transplant patient, you know, in that scenario, given what we know about COVID-19 and outcomes in COVID-19 in patients with cirrhosis, if they are cirrhotic and they have like AIH, for instance, would you still have the same approach to maintaining immunosuppression where it is, or would you, in that setting, consider something slightly different?
That's again an important question in the realm of immunosuppression. Mm-hmm. And again, intuitively, around March, April, we would have said, oh, gee, you know, you got to be careful with these patients. Don't blast them with immunosuppression. And then, well, fortunately, I didn't do anything of that nature in terms of altering my practice. And then there's a paper that's should be out in Hepatology Communications from Autoimmune Hepatitis Network in Italy by Pietro. And they showed that these patients did quite well with ongoing immunosuppression that they had pre-COVID. And then, lastly, the one that gave us all a great deal of confidence that immunosuppression was not bad was a paper that showed that dexamethasone was beneficial in COVID-19. So after that, I said, gee, you know, anything else that should be an academic discussion. Don't tinker with immunosuppression. Treat them like you would normally do. So I wouldn't go out to say confident that immunosuppression might protect them from COVID-19, but you know, we've had very few transplant recipients with severe COVID-19.
Great. You know, I bet you we have all 4 of us have noticed that our patients, especially those with cirrhosis, have been reluctant to engage with the healthcare facility for fears of contracting COVID-19.
Yeah.
Given that scenario, how do you approach your standard practice when it comes to HCC surveillance, esophageal variceal surveillance, routine lab monitoring, when it comes to our patients who have cirrhosis and decompensated cirrhosis, those patients who actually need some higher level of care.
Right. Steve, this is a great question. In fact, I was just involved in helping out put together a program for AASL, the annual meeting on patient perspective and what it should be. And I said we should frame a talk on do's and don'ts. There are several patients who are scared coming to a medical center, and so much so they don't even want to go to a lab, and they are neglecting having laboratory studies done. So for patients with child class B or C on diuretics, they're not going out to check their renal function. And we've had patients present with acute kidney injury because they were over-diuresed. So that's one thing. I've had a couple of patients who were hospitalized with bleeding varices and then went home and are very concerned about coming in for follow-up band ligation. And they increased the interval between band ligation, and lo and behold, they bled from varices and had to come back into the hospital. Cancer surveillance is being delayed. So again, I'm telling my patients, don't delay cancer surveillance. Maybe a month window out of the window is fine, maybe 2 months, but don't go beyond that. So our huge task as hepatologists is trying to bring the patients back to a sense of confidence, and that's what we really need to do. And then patients with fatty liver disease, many examples of people gaining tremendous weight. So we need to educate our patients on trying to stay with healthy lifestyle measures. And now, I don't know what you're seeing, we are seeing a rash of alcoholic liver disease patients. A rash I've never seen this in my life. And we need to try and proactively educate our patients and people out there to really care for themselves, take care of themselves, while it could be emotionally challenging.
Yeah, thank you. And thank you for that, Dr. Reddy. And really, on behalf of all of us on the CLD team, our chief editor, Nancy Rowe, Dr. Steve Gaglione, myself, we just want to thank you and Dr. Bajaj for first of all, for this wonderful manuscript and for taking the time to share some key takeaways with us. And for those of you watching, we hope you found this journal club useful. For more information about COVID-19 and liver disease, please visit us at www.cldlearning.com. Thank you for watching.
Thank you.
Thank you.